Hey everyone, Dr. Armaghani here today to talk to you about the Oblique Lumbar Interbody Fusion, also known as the OLIF. This is a common minimally invasive procedure that I perform on select patients. Patient personalization and individualized care is something that's very important to me. This type of procedure is one of several different ways that we can accomplish the goal of a lumbar fusion. Since not all patients are the same, a surgeon has to have several different types of surgeries to choose from in their toolbox to best treat your condition. The oblique lumbar interbody fusion is one of those. In this video, we're going to be talking about the normal surgical anatomy, step by step how I perform this procedure, and at the very end, we'll discuss risks, recovery, and do's and don'ts post-operatively. If you're on YouTube and you would like to skip around a bit, please click in the links below to find timestamps to move around as you would like. Now that we've completed the overview for this video, let's go ahead and get started. Okay, today let's start talking about the oblique lumbar interbody fusion, also known as the OLIF. Before we can get started talking about what we're going to be doing during the case, we have to have a little bit of an understanding of what normal anatomy looks like. So what you see in front of you here is a normal lumbar vertebrae. What you're able to see is on the right side of your screen, this is going to be where your back is. And on the left side of the screen, that's going to be where the front of your body is. So again, this is the side view here. This structure in yellow is going to be your nerve root. This is the part of your body where it goes down into your leg and can give sensation as well as ability for you to move your muscles. And if you look closely, there is going to be all this white space surrounding the nerve. All this white space surrounding the nerve, that's the space where your nerve can basically settle into. And that space is called the foramen. You want to have as big of a foramen as you can because that means there's more space for your nerve. Over here you have your vertebral bodies. This makes up the building blocks of your spinal column. And in between your vertebral bodies is a disc. Looking here, we have a degenerative spine. As you can see, it looks very, very different from what we saw before. This is looking at the side view of the lumbar spine, with the right side showing where your back is, and on the left is going to be where the front of your body is. The nerve root is in the middle here, and it is in yellow. But as you can see, the area for the foramen is a little bit smaller, and we'll get into why that is here in a sec. What you see here, though, is that there isn't as much space for that nerve as there was before. And let's get into the reasons why. So, in a degenerative spine, a few different things happen. You have disc loss. As you can see here in green, the disc is not as tall as it was compared to normal anatomy that we saw on the last slide. When you have less of a disc, you then start to form bone spurs. Bone spurs are outlined here in the blue. As you look closely, though, you can see that the bone spurs here are encroaching within that area where the nerve lives. What's the name of that area where the nerve lives? That's going to be the foramen. And as you can see here, the foramen is much smaller than it was in the normal spine. So here we see what a normal foraminal height is. Again, the word foramen is a big word for the hole by which the nerve can exit your spine and then go down your leg. The nerve root is here in yellow and oriented again from the side, with the right side being your back and the left side being the front. So again, here is our view of that degenerative spine. As you can tell, you have a very small foramen, which means less space for the nerve. That causes nerve pinching, which then causes the symptoms that go down your leg. So the goal of surgery here is to increase this disc height. And when you increase that disc height, you make the foraminal height taller. When you make the foraminal height taller, or the space for the nerve to exit the spine, you make more room for the nerve root. And this is what you see here. We have a large titanium spacer placed in between the two vertebrae, which have increased the space between them. When you increase the space between the vertebrae, that increases the height of the foramen, which gives more room for the nerve root in yellow. So you may be asking yourself now, where's going to be the incision for this kind of surgery to get that big cage in between my vertebrae? Well, when you're looking at yourself from the front, imagine approximately 2 to 3 inch incision on the left side of your belly. This is going to be a muscle splitting type surgery. So this is not a surgery where we cut out muscle. All we're able to do is we gently split the muscles in plane so that we create as less trauma as possible. This is therefore why we call this a minimally invasive type procedure. Now that we've covered where the incision is, let's talk about some general cross-sectional anatomy. And again, if this is something that's too in-depth for you, just click down into the description below and you can skip ahead in the timestamps to see how I do the procedure step by step. But for those that are interested, let's go over a few things here. So what this is here is a cross-sectional image of what your abdomen looks like. So when we say cross-section, it's kind of like we're cutting you right in half and we're looking at a slice of you, okay? This is going to be the front, which is on the top, and the back of your body is going to be down below. Your abdominal muscles are here in purple. These are your abs, as you would call it. Your intestines are in blue. The intestines are a part of your body which we have to move gently out of the way to gain access to that disc space. Blood vessels are coded here in black, and this involves the aorta and the inferior vena cava, also known as the IVC. We have to be acutely aware of where these vessels are during this procedure. The disc space is our target. That's where we want to get to. This is highlighted here in red, and on either side of the disc space is going to be the psoas muscle. This is going to be another landmark for us to help move out of the way and get to the disc space. Let's hop into how I do this procedure step by step. So if you remember, again, this is our cross-sectional anatomy here, looking at you cut in half basically. So you have your front up here up top, and then you have your back in the very bottom. At this point of the procedure, what we'll be doing is turning you on your side. At this point, you're already asleep, so we're doing this all behind the scenes. So we're going to turn you here on your side. And the reason why we turn you onto your side is we use gravity to then have it passively move your intestines out of the way for us. It's much harder to do when you're laying flat on your back. Then we make our incision, okay? So our incision placement is going to be off to the side in between where the outside part of your hip bone is to where your belly button is. And where that midpoint is going to be about where that 2 to 3 inch incision is going to be. Our target here, though, is to go around the intestines, across the psoas muscle here, in between the vessels, to get to that disc space. So our goal is to follow this green path here eventually, and that's how we're going to safely access your disc. So we'll go ahead and we'll make the incision here. And then what we do is we try to develop a plane between the abdominal muscles, and we use this with our finger actually. So we're able to gently split the muscles in the path that they are. We're not cutting them apart. We're not pulling them out. We're simply just creating space with our finger. After we're through, we try to develop a plane between the abdominal wall and where your intestines are, which is known as the peritoneum. And we do this back and forth, developing this plane gently. And now we have a little bit of a plane here. And as we have that plane, we're able to feel more and more of where your intestines are and where the abdominal wall is. And you can see, again, our path is becoming less and less complicated. Instead of having to go all the way around like we did previously before we ever had to move anything, because of the use of our finger, we're able to have more of a direct path following this green in between the psoas muscle here and the blood vessels here to access that disc space. So we'll go ahead and we'll put our finger in more. And now we're going to gently sweep the abdominal contents toward the surgeon or toward us. So we'll continue to move it out of the way here. And you can see we have an even more direct path in between our psoas muscle and our blood vessels to get to that disc space, which is our target again. After we find the disc in between the psoas muscle in blue and the blood vessels in red, we're able to place our retractor. So we have a very special retractor that goes on this side of the blood vessels, thereby protecting them during this entire procedure. And then we put another retractor to retract the psoas muscle backwards. Now, you can see that real quick here is that what we're able to do when we do this is we're able to open up a space here that gives us a lot of access to that disc space. Again, watch closely. See how small it was before? But with these special retractors, we're able to open them up and create a whole lot more space to expose that disc. With our disc fully exposed at this point, and our blood vessels safely protected by this retractor, and the psoas muscle safely protected by this retractor here, we now have a straight shot to our disc space. At this point, our job is mostly done. We just have to start removing the disc. We do this with this instrument called a pituitary, where we're able to slowly pick out the disc. So we'll go ahead and we'll insert our pituitary, and we'll start nibbling a little bit of the disc away. So piece by piece, we'll start removing this disc space all the way to the other side. And what you can see here is that we've created a channel by which there is no disc. And it's through this channel that we're able to put a cage which can increase the space between your vertebrae. At this point now, with the disc completely gone, we now are able to place our cage. And what we do is we usually just don't put one cage in. We're able to put a small cage in first, then we put a slightly taller one, then a slightly taller one, with our goal of increasing that space between the vertebrae, which again increases the foraminal height, which is the space for the nerve, which is pinched. So by increasing that disc height, or increasing the space between the vertebrae, we give more space for the nerve, and that's the whole goal of surgery. So after we've increased that space enough, and most of this is by feel, generally what we're doing is we're increasing that height anywhere between 5 to 7 millimeters from where it was originally. So now we'll take our cage here, and we'll place it in between our retractor blades, and we'll follow this corridor down to where the disc space is. As we start placing this disc, we do need to turn it, and it will turn with special mechanisms. We place the cage now completely within the disc space in the channel that we created for it when we removed the disc. We then remove the inserter which placed the retractor, and then we slowly remove the retractor blades. When we remove the retractor blades, thereby exposing our psoas muscle and blood vessels again, everything kind of moves back to where it was. So when we remove the tractors, we are then able to sew up this very small portion of the opening where your abdominal muscles were, again, all through a 2 to 3 inch incision. Generally, this part of the case takes about 30 to 40 minutes to complete total. So let's take a look at what we were like before surgery again. Before surgery, we had a vertebrae here and a vertebrae here with a degenerative small disc in between. That small disc led to bone spurs, which then led to a small foramen. That small foramen made it a small opening for the nerve to exit and go down your leg, and that's where your nerve was pinched. So here is your nerve root where the nerve was pinched. After surgery, however, you can tell with this larger cage in here, we created more space between these vertebrae. When we created more space between those vertebrae, we created a taller foramen and then more space for the nerve root. Going back to where we were before, we have our nice big cage in here. We put this cage in safely. We have plenty of space for that nerve root, but sometimes we have to do one more step. And that's where we percutaneously put screws and rods to act like belt and suspenders to hold things together a little bit more. So what we do here is we make small incisions about this big, about 1 inch or 2 on either side of your lower back. And through these small openings, we're able to place screws, then held together by rods. And what this does is it acts like an internal cast to hold everything still while your body heals through this cage and adds new bone. That's going to be the fusion part of surgery. Fusion generally takes about 1 year, but that doesn't mean you can't be doing the things you like doing. After a few months, we generally let patients return to all activities. And that's how I perform an oblique lumbar interbody fusion step by step. What are the risks of this procedure? Well, you tend to worry a little bit about the structures that you have to move out of the way to gain access to that disc space. In this type of procedure, you worry about the blood vessels and the intestines to a lesser extent. One way that we help prevent injury is by asking a detailed history to know if you've had any abdominal surgeries, which could lead to some scarring. We also critically evaluate the MRI to make sure that you don't have any blood vessels that are in different areas than we would normally expect. Ileus is another concern that can happen from time to time. What happens in this situation is, in the process of moving the intestines over and completing the procedure, when you wake up, the intestines don't want to move food across. When that happens, if you start eating and your intestines aren't moving anything through, you tend to get nauseated and could vomit. What we do after surgery is we place you on a liquid diet and wait for your stomach or intestines to wake up again. The way we know that is you start passing gas and we start hearing rumbling in your belly. Once that happens, we know that the intestines have woken back up and we can start feeding you regular food. Nerve injury is another issue that comes up from time to time. If you think about it this way, because you have lost disc height in between your vertebrae, you don't have as much space for that nerve. When that nerve is in a foramen that's much smaller, you can almost think of that nerve as being a little bit shortened compared to what it used to be. Now, in the matter of about 30 or 40 minutes, we increase that height significantly. It can sometimes put that nerve on stretch. When a nerve is stretched, it can sometimes lead to increased pain as well as sometimes muscle weakness. If you develop muscle weakness from a nerve stretch, it generally comes back within 6 months. Muscle weakness is something that we can see as well. Sometimes if you're in one of the upper lumbar levels and you have to really retract that psoas muscle, you may have some problems taking steps, meaning if you're walking upstairs, you may have difficulty lifting your knee up. That generally gets better after about a month or so. Thigh numbness is also something that can occur from time to time as well. This has to do with retractor placement and stretching of some of the sensory nerves around your abdomen. If that occurs, you will have some numbness or tingling on the front of your thigh, particularly on the left side if it's going to happen. This also gets better within about a month or so. Lastly, we worry about bone collapse around the cage. If you think about it, you don't have a lot of space in between your vertebrae. This is why we're doing this surgery. So in the matter of about an hour or so, you have a lot more height in between those vertebrae. The body also wants to come back to what it's used to. So if you have soft bone or are osteoporotic, sometimes that bone can collapse into the cage. So instead of having, let's say, 10 millimeters in between your vertebrae after surgery, as time goes on, that may decrease to 7 or 6 millimeters, which can sometimes lead to increased pain. This is infrequent when it occurs, but we tend to pay more attention to it in people who may have soft bone or a history of osteoporosis. What's recovery like after this procedure? Generally, you're going to spend 1 to 2 nights in the hospital, and then you're going to go home with family. You're going to have back and or abdominal pain following this procedure just from the incisions. Also, if you think about it too, because we're increasing the height between your vertebrae, you can also feel a little bit of a stretch or a whiplash type injury in your lower back because of the stretch of the ligaments that were holding your bones together previously. This steadily improves over the course of about a month or so. Another thing that I want you to pay close attention to is the recovery process of your nerves. They take about a year to reach their maximum recovery potential, so no snap judgments on this procedure at all. This is going to be a marathon, not a sprint. One thing I try to really tell all my patients following any kind of spine surgery is that nerves are fickle. It takes a very long time for a nerve to recover. Generally, it takes about 1 year for a nerve to recover to its full extent. How you feel at 1 year is going to be how you feel long term. Another thing I try to tell my patients is that the recovery from a nerve injury like this is going to be up and down, particularly within the first 6 weeks. Think of it this way. Your nerve has been compressed for so long that it's no longer able to get proper signals from your brain. So the leg in turn tries to turn up the volume so it can hear the signals from the brain better. But in the course of about an hour or so, all that compression is gone, and now your leg is getting normal signals from the brain, but it's very hypersensitive. Some days following surgery are going to be great. You're not going to have much pain at all. Other days you're going to feel like you never had surgery to begin with. You just need to give your nerves time to re-equilibrate and turn down that volume so it's not hearing the signals from the brain as much as it needed to previously. This takes about a month to get better. What can I do post-op? Once you leave the hospital, the bandage that we have on should stay on for 3 days. The reason why that happens is because we want your skin to really get watertight before we allow you to shower. After 3 days, you can remove the bandage that we placed at the hospital and you can shower normally. Let soap and water run down your back or abdomen, pat it dry afterwards, and if you'd like, put a new bandage over the top for the first week or two. The reason why I say put a new bandage over the top is because the incision sometimes lies in your pant line and you don't want to rub on the incision. You also have butterfly strips that are covering the incision. Those should fall off on their own as you start showering. If they're not off in about a week or so, you can remove them. The vast majority of you are going to have stitches that are all on the inside, so you don't need to come back to clinic soon to get them removed. Occasionally, you will have staples, and we will let you know if you have staples to come back and see us within a couple weeks. From a restriction standpoint, we don't want you bending, twisting, or lifting greater than 20 pounds for about 3 months. We want your body to start healing and creating some of that early fusion mass between the bones. After 3 months, the bones start to get a little bit more sticky and we can increase your activity level. If you have a job that doesn't require you lifting frequently or bending or twisting, you can go back when you feel up to it. But if your job requires you to lift greater than 20 pounds, we would like you to modify that duty to either light duty, or we can write for you to be off of work until 3 months passes and you're safe to start lifting again. We want you to walk as much as you want. The goal of this is to help recreate the connections that were lost from the muscles in your leg up to your brain. Lastly, from a pain management standpoint, we don't want you taking any anti-inflammatories after surgery because it does decrease the rate of fusion following these procedures. Examples of anti-inflammatories include ibuprofen, Motrin, Aleve, Advil, Mobic, Celebrex, or naproxen. What you can, though, take is 1,000 milligrams of Tylenol 3 times a day. Just take it with breakfast, lunch, and dinner. Even though you may think Tylenol isn't doing a whole lot for you, it does give you a good steady-state background amount of pain relief so that you don't have to take as much narcotic or muscle relaxer following surgery. Generally, my patients are off of narcotics by about 3 to 4 weeks. Sometimes that extends out to 6 weeks in severe cases. So there you have it, the Oblique Lumbar Interbody Fusion, also known as the OLIF. Hopefully after this video you have a better understanding of the anatomy of the lumbar spine, step by step how I perform this procedure, and what to expect post-operatively. If you're curious about the conditions that can be treated with this particular procedure, please see the links below if you're on YouTube. And while you're there, please hit like, comment, and subscribe to be notified about other educational videos such as these. To make an appointment with me, you can find our office phone number in the links below, or you can click Book an Appointment above if you're on our website, www.armaghanisspine.com. You can also find me on these platforms here if you're interested. And thanks again for taking time out of your day to learn about this procedure with me. Take care.